good primary stability in different clinical and anatomical situations. This, of course, is the first observation. Then let's look at the correlation between the real insertion torque and the real RFA. As many others before us, we were not really able to find a statistical significant correlation. So you see the Spearman correlation is very poor. So this value is good when it's close to 1, so we are far away. Even so, if you look at this chart, table, what we can see that most often when we have a high insertion torque, we have a tendency to have a high RFA value in 80% of the cases. Nevertheless, that means that in 20% of the cases, this doesn't happen. This is not the case. So, right, we have didn't meet any statistical correlation between those two values. And this, of course, confirms what Lars have published many times, that RFA and insertion torque are two good parameters to evaluate primary stability, but they measure different things. The first is indicating the resistance to the bending load, and the insertion torque is the resistance to the shear forces. Result. As you can see, the mean difference between the real RFA and the perceived was -1, again with the huge range here. While the mean difference between the perceived insertion torque and the real and the perceived insertion torque was again -1.3, again with a huge range. So generally, we are underestimating the primary stability. So as you can see, when we are in the low range, we perceive the RFA as low, but it's lower. Actually, it's much lower. And the same happened for the insertion torque. We feel that the implant was treated with like a poor insertion torque. Actually, it's much poorer. It's poorer. In the high range, we have the tendency of opposite. We overestimate. We felt that the implant has a good primary stability, well, it's even more. So considering, again, the mean perceived value of primary stability generally is underestimated. Nevertheless, the analysis of the previous table show that the underestimation is particularly evident, again, when primary stability is low or medium, where there is an overestimation. When the primary stability is actually high, the range of mistake you see can be extremely variable up to 60 ISQ or 38 Newton centimeter. So again, this is the correlation between the perceived RFA and the real RFA. And again, what do you see? That we perceive, for example, here, in 85% of the case, we were right in guessing that the implant has a high RFA, but of course, in 50% of the case, we were wrong. Or here, we understood that the RFA was low, but only in 20% of the cases. So, of course, that could bring to several mistakes. This happened also for the perceived insertion torque. And again, very quickly, you can see here that we got the feeling that the implant has a high torque, and we were right in 78% of the cases. That's good. But in 22% of the cases, we were wrong. And again, I want to underline that this has been done by an experienced surgeon who has placed the same kind of implant for thousands and thousands of numbers before. So, of course, this is a situation. Well, so in conclusion, the accuracy of primary stability prediction is not good enough to prevent mistake when we use an immediate loading technique. So we encourage very much to use systematically any kind of objective measurement, either for ISQ or in sensor torque. I thank you very much for your attention.
Thank you. Thank you very much, Dr. Degidi.